All right, folks, it's our special edition of clinical updates on Healthcare Unfiltered. And we have a dear friend and colleague, although it's his first time on Healthcare Unfiltered. Ben, welcome to the show.
Thanks for having me. Glad to be here.
A local Chicagoan on the show, always a pleasure. We need to figure out a way where I could do this live for people who live in town, but I don't know. I think it's much easier and faster and would to do it on Zoom.
There you go. Whatever works.
Yeah. So let's start by just telling people about you a little bit. Just tell us about you, what you do, and what got you into myeloma. Was there a reason that you decided to specialize in myeloma?
I'm Ben Derman, as you said, and I'm an assistant professor at the University of Chicago in the myeloma program. And I'm a Chicago lifer, so I spent all my time in training and into facultyhood in Chicago. When I was a medical student, one of the first patients I saw on the medicine rotation, my IM rotation, was a patient with myeloma. And they had all the fixins, they had renal failure and they had bone disease and new fractures. And I just remember being so fascinated by all the different parts of the body that went awry when they got myeloma. And that got me really interested in it. And just sort of learned more about it. I got to work with some amazing mentors over the years who had a passion in it for treating patients. And also, during my training was a time, I mean, it was 2015, was a critical year in myeloma. There were all these drug approvals, especially a lot of these combo regimens. And I started getting these updates, and following it and saying, like, there's something going on here in myeloma. We're seeing a lot of progress here. It's pretty amazing. So that's what really got me interested. And then when I ended up at University of Chicago and working with Andrzej Jakubowiak there, he has just such a love for treating myeloma and for research that it was infectious. So now I do a lot of work really across the spectrum. I get to treat all sorts of patients. So I do CAR T and transplant and standard myeloma therapies, which are not so standard anymore. And um, and then I do a lot of work on the intersection of minimal residual disease or measurable residual disease, as we're beginning to call it, and treatment decision making in myeloma.
So you run clinical trials and you probably collaborate with folks in the lab, or do you do any lab work?
Yeah, we get to do both. I sort of bridge the gap. I'm not in the lab myself, but we do a lot of translational work with the lab that we have or with other, third parties
Yeah.
over the years. Yeah.
It's a fascinating field, I have to tell you. I mean, from the day when I was an intern and I took care of myeloma patients, and I did give people melphalan prednisone, Ben. Just so you know. I mean, you may not, you may read this in history books, but I did give actually melphalan prednisone back in the day.
Well, it's funny that you say that. I saw a patient not long ago, and in their chart, it kept saying that they got DARA VMP, and I said, "Who's giving melphalan and prednisone to this transplant eligible patient?" And I was like, we don't really use that here." But it was methylprednisolone that they were getting. And so I was like, okay, fine. I still have not seen anyone who's gotten melphalan prednisone as an upfront therapy. Of course, we give lots of melphalan as part of transplant, and I can safely say I've only had one patient I've had to give thalidomide to, and that's about it.
But really, it's a field that has really progressed amazingly. I mean, I'm sure it's very rewarding to you and your colleagues in the myeloma program to almost transform this into a chronic disease. Of course, with that comes challenges into what to do first. How do you decide on a lot of certain elements? But I asked you to come on the show specifically today to really focus on ASCO and the European Hematology Association meetings that just happened. And hopefully there were some data, some abstracts, some information that are worth sharing with viewers and listeners. So really the floor is yours. You get to decide what you think is really relevant and what's important. And hopefully there are five or six of these abstracts that you think you want to share with us.
Yeah. Well, maybe let's just go chronologically through the patient journey. I think that's maybe makes the most sense. And obviously, newly diagnosed myeloma is a critical piece here. We're not going to, we can skip the smoldering for now, but newly diagnosed myeloma, I think there were actually a really key theme across ASCO at least, and in a little bit of EHA as well, which is that for a lot of patients now, whether they're transplant eligible, as we say, or transplant ineligible, but pretty much for many patients up to age 80, let's say, who are fit, we're now routinely using quadruplet therapy. And when I say quadruplet therapy, I'm talking about a CD38 monoclonal antibody, typically with VRD, occasionally with KRD. And this has been something that we've been doing for many years now, since the original randomized phase 2 Griffin trial. But I think now I'm seeing, even with referring providers, that many are just routinely going to quad therapy up front, regardless. And it's kind of nice because you don't have to be thinking about whether they're transplant eligible or not. You just say, can they get the quad or not? But I think then the question that we have is, okay, quad therapy seems to be better than triplet therapy, but where does transplant fall into this? Are we getting to a point where we can use less and less transplant? So there are some designs that were presented at ASCO where I think we are starting to get a window into that. So let's take actually the MIDAS trial. I think that was one of the most impactful studies for me coming out of ASCO. And it's right up my alley because this is using MRD to guide decision making around transplants. So it's a very innovative design. So patients would get isatuximab, a CD38 monoclonal antibody, with KRD, and they get 6 cycles. After the 6 cycles, they're randomized based on their MRD results. If you were MRD negative, which in this case was defined as less than 10 to the minus 5, so you had to have less than 10 cells per million or 1 per 100,000. If you were MRD negative, you got randomized to go to transplant or 6 additional cycles of quad therapy. And then they went on to maintenance therapy. If you were MRD positive at that same threshold, you were randomized to go to a single transplant or a tandem transplant. Now, here's where it gets interesting. The primary endpoint of this study was actually looking at MRD negativity at a deeper threshold, at 1 in a million, which is sort of the limit of detection of the assays that we have that was done in this study, which is basically clonoSEQ, which is NGS. So let's break them down one by one. I think the easier one to break
Just one
down.
second, just to
Yeah.
clarify though, so MRD negative and MRD positive both received transplant, essentially.
In one of the arms in the MRD positive group. And this is, by the way, regardless of cytogenetics. So you could have a high risk patient in the lower intensity arms. You could have a standard risk patient in the higher intensity
Right.
arms. So the MRD positive group were randomized to get a single versus a tandem transplant, which is not used much anymore. But it's still something that's been recommended occasionally for high risk patients and is probably more commonly used in Europe. So this was done mainly in France. So what they found is that there was no difference in the MRD negativity rates at the end of these treatment paradigms. So whether you got a single transplant or a tandem transplant, somewhere around 40% of patients or so were able to achieve the deepest level of MRD negativity, but they were not significantly different. And a lot of people see this as maybe the nail in the coffin for tandem transplant. We don't really have PFS data on this. We actually don't. I mean, there was only about 15, 16 months of follow-up. And we certainly don't have overall survival. But I think everyone was just looking for just another piece of evidence to say, we don't really need to do tandem, do we? And so, I think it would be useful to see what happens with the quote unquote high risk patients or the highest risk patients and see what happens among those patients. But, if I needed any push, it's just another level of evidence to say, not sure tandem transplant adds much over a single transplant.
How about the MRD negative one?
The MRD negative one's the more interesting one in my book, which is that there was also no difference in MRD negativity rates at the end of the consolidation piece. So whether you got a transplant or 6 cycles of ESA KRD, 12 in total, there was no difference in MRD negativity rates at 10 to the minus 6th. And this is where it gets really interesting, right? Because do we think that there's really going to be a progression-free survival benefit now when post-consolidation we don't see any differences? We just heard a year ago at the FDA ODAC around MRD for surrogate markers as a surrogate marker that the FDA sort of accepted that this 9 or 12 month MRD negative rate is likely to be correlated with PFS at least. And that's kind of what you're looking at here when you're talking about MRD negativity after these consolidation pieces. I mean, if you want to be a staunch, a truist in terms of analyzing this trial, you should say we should wait for PFS. And it's important to note that high-risk patients potentially were randomized to a non-transplant approach if they were MRD negative after 6 cycles. So some people say, well, look, we see all the time people with high-risk disease respond very quickly, and maybe they can even get to MRD negativity, but it's unlikely to be sustained in those cases, which means 2 consecutive negative tests of maybe a year apart or so. So I think longer follow-up will be really instructive, but certainly the reviewers for New England Journal thought that this was important because it's now published there. And, I think the implications for practice are almost immediate in some ways. I mean, if I had a patient who's MRD negative, even after 6 cycles, and you can use your 10 to the minus 5 threshold, you don't even have to use the lowest threshold. I think I'd be very much okay with bypassing transplant in those patients, you know? So it's something that you still may want to collect stem cells, but I think you can offer them at least that possibility.
Can I ask you a question on this? That's very interesting and very nice abstract. Thanks for sharing. And it's a paper, like you said now. Um, Now that for the MRD negative, do you forego maintenance?
No, all those patients, you mean in the trial, I assume you're talking about, or do
Oh,
I in general?
yeah, like, right. I mean, I think one of the nice things about MRD, I think negativity, in my view, can I de-escalate therapy? Can I really spare patients some treatments now that I really have a molecular evidence that there is really no disease? So am I, you know, in real life right now, are you able, for some MRD negative patients, do you say, I'm not going to give you maintenance therapy, or do you feel still uncomfortable doing that, not doing that?
You know, and you're asking somebody who, I mean, we designed a trial specifically looking at this called MRD to Stop, where we actually stopped maintenance therapy for MRD negative patients. But those are people that were already on maintenance. The master trial was really the only study that sought to so far study what happens if you stop treatment without any maintenance therapy for MRD negative patients. People who don't have high risk features seem to do very well with that approach. People with high risk features, especially if they have 2 or more high risk cytogenetic abnormalities, tend to do very poorly with that approach. So the answer is probably not the same for each individual. In general, I'm still offering at least some maintenance to patients, mostly because what I'm really looking for is sustained MRD negativity. And you just can't prove that without enough time.
Right.
So if people are only achieving their first MRD negative result after 4, 6, 8 cycles of induction or post-transplant, they need about a year, right, in order to show that. At that point, then I start having the discussion with them, especially if they're standard risk, to say, listen, do we want to talk about de-escalating further or discontinuing at all? But I want to just stress that's very much not exactly evidence-based at this point. The dramatic trial, which is comparing 2 years of Dara-Len versus Len, and then using MRD negative patients who can stop, they're randomizing MRD negative patients to stop or continue, might help to answer that a little bit better. But all the data for maintenance therapy was especially for lenalidomide, was generated in a much older era of myeloma therapy.
Yeah.
Very few of these patients got triplet therapy. Okay, that's it. So all the evidence for maintenance is there. One last thing I'll say, Chadi, is that if you look at there was this trial called Cassiopeia, which was Dara VTD versus VTD, and they all got transplant. But there was a second randomization to Dara or observation, and everyone criticized this trial because they said, "How can you randomize people to observation?" But the thing is, 35% of the patients who got quad therapy were MRD negative right after transplant. It increased to 50% in the observation arm at 1 year. So what gives? how did they deepen their response? Is it a delayed response to transplant, or is it, the immune system? I don't know, but the outcomes of those patients are excellent.
Yeah.
So there probably are people who don't need maintenance. We just don't know exactly who they are yet.
Okay, that's a great paper. Next.
Well, building on that, there were two studies that were presented, one by Ola Landgren, which is called the Advance trial, and the other one was an update from the ISKIA trial by Francesca Gay. And these were comparing quad versus triplet in frontline. But the ISKIA trial, which has been presented before, they showed something interesting. So they did ESA KRD versus KRD, everybody went to transplant, and then they still got more consolidation after that. They got ESA KRD or KRD. There was no second randomization or anything like that. And the initial results that they presented was that MRD negativity rates, before they started the sort of longer consolidation piece where they got more treatment after transplant, was strongly in favor of the quad regimen, by about, it was like something like 45% for the triplet for KRD versus about 67% for ESA KRD. But with longer follow-up now, they're almost looking like head to head, and there's not as much of a difference anymore. And it begs the question, you know, if you're not giving four drug therapy, or even if you are, do people just need to be on more treatment overall? Will that solve it? Right? So it's the opposite question of what you just were bringing up. And I don't, we don't have PFS data yet, so it's hard to say. I don't know why we don't have PFS data yet, probably because there's no difference between the arms. But for some patients, it seems that there may just not be any shortcuts here. And the advanced trial showed that early on, same thing. Four drug therapy beats three drug therapy. But, the outcomes are so good that if you continue triplet therapy, perhaps for a longer period of time, maybe you can make up some of the differences. But I think we're all looking to de-escalate, not to intensify treatment. So, that's just sort of wrapping up a little bit on the frontline piece.
What
But I think, yeah.
speaking on frontline, just to digress for 1 minute, what are you seeing in the real world from your colleagues in the community, referrals and so on? Um, are you seeing quads, like what are your observations from the referring community oncology side?
Um, you know, in the last year and a half, I'm seeing a lot more people who refer to transplant to me who are already on quad therapy. It used to be that I would see them after one or two cycles. I'd recommend to be adding a CD38 monoclonal antibody. Now, I think almost everybody is starting on that. But one of the implications of this is those rare patients who don't respond well to quad therapy up front, to me, and this is not saying anything profound per se, but there's something very different about what happens to those patients when they relapse.
Mhm.
And the decision making around that. It used to be that if you're having a suboptimal response to quad therapy, and what everybody considers a little something different with suboptimal response, but um, it used to be that we would say, well, keep going on treatment before we go to transplant, or we would switch treatment. Maybe we would swap if they're on Velcade or bortezomib, we would switch it for carfilzomib. But now we have CAR T here, and it's almost like a cheat code, right? Where you can just say, maybe I should just give up on this transplant thing. What's the odds that this is going to work well in this patient? Maybe I'll just go to CAR T in this case. And so, this is one of the conversations that we're now having with patients is, when do we make that decision to just jump to CAR T? Because it's potentially going to give them many years of treatment-free survival, a treatment-free period. And we can talk about, the long-term follow-up from CARTITUDE-1 and some interesting things from CARTITUDE-4, which was the earlier line study. But to me, there's a potential impact, a positive impact on their quality of life if they go to CAR T. So, and I don't have as much confidence that the early relapses on quad therapy respond to our conventional chemotherapies as well as maybe they used to when they were on triplets.
Yeah, makes sense. Okay, I'm loving this. I'm learning so much. Let's go next. We finished the front line. I think I like
Let's
the
do
you're
let's do early relapses. I want to talk about the Carditude platforms, which is for cilta-cel, of course. And just to give your listeners a little bit of lay of the land right now, when we were starting out with CAR T, we had ide-cel only that was approved, which is known as Abecma. Then we had cilta-cel approved a year later. And they were for people who have had 4 prior lines of treatment. So this was like a last ditch effort, oftentimes for patients. I wouldn't say that, but at least late lines. Then we had 2 randomized phase 3 trials, which led to their approval for earlier lines. Ide-cel is approved for patients with 2 or more prior lines of therapy now, and cilta-cel is approved for patients with 1 prior line of therapy, even. So you can give it even as early as second line. Made the New York Times that in the late line setting, Carditude-1, which was the first, larger patient study with cilta-cel, that 33% of patients were alive without progression at 5 years. And the question is, are we starting to see a tail? Are these people functionally cured? And, talking about that. And it's pretty amazing. We participated in Carditude-1. We've seen a lot of, these long-term responses, durable responses. And I think it's a really important question now to figure out, if we use this drug even earlier, are we going to see even higher percentages of long-term responders? And so Carditude-4 has, been presented now a number of times. It's been published on, but there was actually a very interesting poster that was presented, which was a subgroup analysis of Carditude-4. So this is cilta-cel in 1 to 3 prior lines of therapy. And the first thing is that there's an updated, the follow-up is about 33 months now. This is from the last cutoff was 2024, but for the study that they presented, the cutoff was around 33 months. And what they found is that the median progression-free survival for patients getting cilta-cel who had high-risk cytogenetic abnormalities or high-risk features was 37 months. So I just want to give context to that number. In the original phase 2 trial with heavily pretreated patients, the median progression-free survival was about 34 months. So this is in the high-risk group with earlier treatment. It's already, at least that, and maybe a little bit surpassed that at 37 months. That's compared to only 10 months in the standard of care arm. Now, the standard risk arm, we haven't even reached the median progression-free survival there. And the question is going to be, there's a lot of censoring around that 3-year mark, but, we're over about 70% of patients who are alive without progression at 3 years. So I'm really curious to see what's going to happen to these standard risk patients, especially because this, to me, is certainly a higher number than what we saw up front in initially with Carditude-1. And one other thing that I'll mention about this study, though, on the negative side, is that when you look at patients with extramedullary disease, this is becoming a key focus in myeloma, that this is a group of patients who have disease outside their marrow, soft tissue lesions. They behave very differently. And their PFS in this study was only 13 months, actually just under 13 months. So we clearly have a lot of work to do with that specific group. But, for everyone else, these outcomes look pretty fantastic.
That's amazing. So for the extramedullary one, are there ongoing studies now try to address this quote unquote unmet need, it seems like?
Yeah, so it's that actually segues really well. It's almost like you do this for a living. It segues really well into the EHA abstract. So there was a late-breaking abstract looking at a combination of bispecific antibodies specifically for patients with extramedullary disease. So teclistamab, which is a BCMA bispecific, and talquetamab, which is a GPRC5D bispecific, they're both FDA approved for late lines, 4 or more prior lines of therapy in the US. But there was a study called Redirect 1, which was actually published in New England Journal last year, where they found pretty promising results as a combination strategy. And they noticed that the subgroup of patients with extramedullary disease did about as well or better in some cases than any previously published data. And so they actually ran a study specifically for patients with extramedullary disease. And the late breaker was that with 13 months of follow-up, 61% of patients were still alive without progression at the 12-month mark. And the median progression-free survival looks to be around 15 months. So, traditionally what we've seen, albeit apples to oranges, is that CAR T, especially cilta-cel, has offered a much longer progression-free survival than what we've seen with bispecifics. Again, we can't compare head to head, or we don't have a head-to-head comparison. But when you look at this combination strategy, it actually seems to rival CAR T. When you have a median progression-free survival of 15 months in this extramedullary group, I just told you, even in earlier lines with cilta-cel, it was just under 13 months. So, do you have to wait and go through the process of CAR T when you have these two drugs that you could combine right away and get started? One of the tricky parts about extramedullary disease is, maybe more from a trial perspective, but it's a real life issue also, is how do you know if they're responding? If they have high light chains or a high M spike, great, awesome. But really, you need PET scans or you need CT scans. You need some imaging to show you, just like, in solid tumors or in lymphoma, for instance, where you need the imaging in order to show it. So when you look at median time to response, for instance, it's obviously going to be much slower with this type of treatment because you can't adjudicate a response until you've done imaging, and you're not doing imaging every month, let's say.
Right.
So anyway, very promising results, I would say.
How often do you see that? Like, what's the prevalence of extramedullary in myeloma? I mean, it's like just to understand how, I guess, how common this issue is.
Previously, it was pretty rare. Um, I'll tell you anecdotally, it feels like the incidence is increasing. And, there's a lot of theories that have been thrown out there as to why this might be. Is it that the more treatments that we use, we're sort of selecting out some of maybe these uglier clones,
Mhm.
especially at relapse? Because we know that extramedullary clones tend to be having more of these subclonal populations that maybe are driving resistance. It could be an issue of penetration into the lesions, right? Where we're not killing off as many of these cells as we should be. Or it could be that patients are living much longer, and all of these people who had ugly cytogenetics and such that probably would have not survived very long are surviving much longer, to the extent that we're seeing a different natural history of the disease now than we ever did. And I actually think that has a lot to do with this.
Yeah.
Uh, but I continue to see some very odd, peculiar presentations of extramedullary disease that I hadn't seen in the previous, 5, 6 years. So I would say the number is increasing. Post CAR T, it seems to be increasing especially. And it's frustrating because a lot of these cases are non-secretory, meaning they don't make a light chain, they don't make the M spike. So we can't even detect these things in the blood until somebody has new symptoms or it
Mhm.
becomes obvious because they have, subcutaneous nodules or something like that.
Fascinating. I mean, these are not like, the plasmacytomas where you have like only one location. This is very, very different, obviously, biologically. Okay, what is next?
Ooh, where should we go next? I think we should hit on tri-specific antibodies because that's pretty fun. This
Yeah.
is pretty fun. Tri-specific antibodies. So for those, keeping up at home, we had CAR T, we had bispecific antibodies going after a target antigen on the myeloma cell, and then we have CD3 on the T cell. Now we're doing tri-specific antibodies. So we keep the CD3 on the T cell, but now we're going after two different antigens. So, the first one that I want to talk about is a tri-specific that involves targets that we're probably all familiar with now in myeloma, which is BCMA, B cell maturation antigen, and CD38. So there's a product called ISB 2001 which is a trispecific antibody. And this was studied in a, heavily pretreated patient population. 34% of the patients had extramedullary disease, 40% had high-risk cytogenetics. And as far as prior BCMA therapies, almost half of the patients had a prior BCMA therapy, and basically everyone had CD38 treatments, and most were refractory. And so this was a dose escalation study. So, obviously the lower doses may not be as efficacious. But what was pretty amazing is that there were no dose-limiting toxicities noted on the study. And when they looked at this population of patients with at least 1 month of follow-up, the response rate was 80%, including 30% who had complete responses and almost 75% of patients with MRD negative results who were able to be evaluated. And this was really agnostic to whether they had prior treatment with a BCMA therapy or not. So that's what's pretty amazing to me. And, this study is now undergoing a dose expansion phase, but this works even with prior BCMA therapies. And so the question is going to be, what does it look like in a BCMA naive population from a PFS standpoint? I mean, I think we get caught up in response rate because that's the quickest outcome. And I think drug companies like to, want you to believe in that hype. But the what you really have to pay attention to is what is the durability of the response. And right now, we just don't have enough follow-up. There are many patients who are ongoing on treatment. 90% were still ongoing at 6 months. So we at least know this is durable beyond 6 months. But then, we'll hit the 12-month and 18-month and 24-month. And so it remains to be seen. But this one certainly looks like a winner for the future and something to be paying attention to.
Yeah, no, we need to. The one thing I would say about response though, Ben, and maybe I'm just have the optimistic view. Like I understand when it comes to responses in solid tumors, when we kind of measure like, 5 millimeters and do the RECIST, which I hate the RECIST, but it is what we have. I kind of feel in myeloma, it's just a little bit different because you've got this easy to measure in the blood, like,
Right.
biomarker in essence, like you really have it's just a bit different. It's not just like, shrinking a mass that's sometimes subjective on the radiology and so on. I actually have an actual measure. I'm looking at the protein and the M spike and all of these things, and those all correlate with the activity of myeloma. So maybe, I mean, I think I agree with you. We get hooked on the response rates, and response rates always don't mean much unless patients live longer or better and so on. I feel there's something unique about myeloma because we have such an easy biomarker to measure.
Yeah, but even within that, I mean, I totally agree with you on that. I feel spoiled that I can come in every week almost
Right.
and tell a patient if you're doing well or not, except when they become non-secretory, and then it's the most frustrating thing in the world. But, there are some downsides to it, and not all responses are the same. So, light chains, for instance, have a half-life of 5 to 6 hours. They're going to wash out pretty quickly. If you're responding quickly and you have measurable light chains at baseline, there is nothing better. It's like the most amazing thing because you can see people respond so quickly. But if you have an IgG kappa myeloma protein, it takes a lot longer. The half-life is at least 21 days, and we know that there's recycling, so it can be frustrating. People take a lot longer to respond. And it's also dependent on disease biology too. So patients who have an 1114 translocation, which is the weirdest myeloma, they're the weirdest myeloma subgroup because it's high risk if it's plasma cell leukemia, but it's standard risk if it's not. It responds the slowest of everything, but it's still considered a standard risk abnormality. In that MIDAS trial that I mentioned at the very beginning, most of those patients did not reach MRD negativity, and they're randomized to the more intensive arm, but it's not a high risk abnormality, so it remains to be seen how that affects things. So the kinetics of the disease are different for different individuals. It's the multiple myelomas, right? Which is why MRD negativity in some ways can usually get around at least the protein kinetics problem, can't get around the biology problem that we mentioned. But either way, MRD negativity seems to be a great measure of what's going on as long as you're measuring it in the bone marrow. But for these extramedullary disease or other patients, what do? You need a peripheral blood marker, and that is something that, we're on, it's ongoing in development.
You got
Um,
two more in you?
I got one more. I got one
I'll
more.
take one. I'll take one.
One more, the other tri-specific. I can't let this go because this was a big deal at both ASCO and EHA. So this was also from J&J called J&J 5322. They need a good name for it. But it's targeting BCMA and GPRC5D along with CD3. So another tri-specific. And they enrolled also really heavily refractory population. 100% response rate in the recommended phase 2 dose if you had never received a BCMA or a GPRC5D treatment. 100%. And
Wow.
70% of those patients are in a complete response. This thing is
Wow.
really powerful. The response rates are not quite as good if you had a prior BCMA or GPRC5D treatment, especially a bispecific. It was closer to maybe 50 to 60%. But with longer follow-up, we're going to figure out what's going on with this drug. But the main thing that's also cool about this is a lot less toxicity than what we've seen with talquetamab, which causes skin changes that sometimes desquamating skin rash, nails to sometimes fall off, and significant taste changes and weight loss. This is significantly reduced with this drug. So that could make not only the bispecifics more tolerable in a way by doing it as a trispecific, but we might end up seeing better durability of response as well. So that remains to be seen. And I think if that's all you take away from that, you're up to date on myeloma as far as I'm concerned.
I like that. I like that. That's the goal. The goal is to update everyone on myeloma. This was so much fun. Really, just, I mean, we gotta do this at least twice a year. You guys are just moving things really fast, I have to say.
It's
And
hard
we're
to keep up.
smoldering. We're gonna stay away from smoldering right now.
I thought you probably have, covered that to some
I
extent.
covered that many times.
It's all
Unless
good.
there's something pressing, I think we're good. No, thank you so much. This was really very helpful, and I think I'm pretty sure we're going to have some stuff coming out at ASH, and it's hard to believe that we are airing this in the summer of 2025, and before you know it, it's ASH. So let's not think about that. Let's just
Right.
enjoy the summer. Ben
Okay, sounds
Derman from
good.
University of Chicago, thank you so much for coming on.